So this morning we started off with a discussion about the system under pressure, and this afternoon we're going to hear now from a very interesting set of presentations around actually conducting rapid evaluations in that challenging context. We've got three presentations. What we're going to do is they're all going to be roughly 10 minutes each. We're going to run through the presentations first and then take questions at the end. I'm going to introduce them in turn though. So I'll start off with our first presentation is by Chris Charlo-Johnson. He's from a senior fellow at the Nuffield Trust, and he's also co-director of Reset. Chris.
Thank you, Paul, and good afternoon, everybody. So this is rapid evaluation with scarce data, and it's essentially based on some personal experiences of conducting rapid evaluations with part of the Reset team, and from earlier experiences as well of evaluation. And I imagine some of the parts of this topic might be familiar for people who've embarked on rapid quantitative evaluations, or at least attempted to do so, may be familiar with it. And it might be useful if people had their own experiences and things that they wanted to share afterwards with this as well, because what I'm saying is probably not definitive. So I'm going to describe some of the issues and then illustrate our approaches with a couple of Reset evaluations. I'm not recommending cutting corners, and I'm not avoiding robust evaluation. A lot of this is really about prior work that will enable robust evaluation in the future at a later date, if that is the right way to go about things. So what are the issues? Well, imagine if people starting on evaluations may find that this is quite common. You find that data just isn't there. It may be a very new service that's just started up. They haven't really started collecting it. Or they may just be starting to collect some data, but it may not be the right data. It may not be very good quality, particularly if there are pressures on the system. The priority around collecting good quality data and complete data may be quite low down the list. Data may not be obtainable within the time frame, particularly if you're looking at longer term outcomes. For example, if you're evaluating a cancer screening program, for example, you won't see a lot of outcomes for there would probably belong quite a few years down the line in terms of lives saved, etc. There may be issues about data that can't be linked. So there may be different data collections that are going on with the service, but there's no means by which those are being linked with, say, routine hospital data, for example. And sometimes it may not even be clear what data is actually needed to actually evaluate this particular service. Okay. So I was saying, when the system is under pressure, of course, a lot of these will be exacerbated. And particularly things like even just getting hold of, as an evaluator yourself, just getting hold of data and getting engagement with people in the service who've got so many other pressures on them as well at the same time. So what are the options that they have? Well, I think just to repeat what Judith was saying at the beginning of this conference is that scoping is really important here. And careful scoping is required to reflect what's likely to be achieved. So, and deciding the right endpoint is crucial here. So on the left-hand side, I've got a list of sort of viable endpoints. At the top, I mean, the question is about the service or the new innovation. Is it effective? Well, in many cases, you're not going to be able to answer that question within the rapid time frame for various reasons, particularly because of the data that's available. You might just sort of get some ideas that it might be effective under certain situations. Can it be effective? Maybe qualitatively find that there are quite some nuances which might then turn to think how it could be effective. You might be able to find out whether it's safe. You might be able to do some analysis to find whether it's equitable, just by looking to see who is actually engaging with the service and who isn't engaging with the service. Or further down the list, we might have a framework, be able to build a framework that enables a more formal quantitative evaluation in the future and make recommendations about data collection and data interfaces. So these are all the sort of different endpoints that could be designed within the evaluation. And various approaches I've got there on the right-hand side, listing from sort of statistical analysis, sort of a lot of backroom hard number crunching, going all the way down to service and stakeholder engagement, actually finding out on the ground what actually does the data look like? What are the data collection processes that exist? How do you actually measure the outcomes here? All right. So the first example is an evaluation of a hospital-based youth violence intervention program. Now, this was a mixed method study, and the quantitative parts, which is what I'm going to be talking about, is just a small part of it. There's a large qualitative part of it as well. And the idea is basically that within hospital emergency departments, there is a youth violence intervention program. There's about 3 charities in the country that run these. And the idea is that if a young person is coming in to the emergency department and it's suspected that they may be victims of violence, assault, or of exploitation, then they will offer to engage with this person, and this engagement would then require aiming to sort of stimulate behavioural change or improve their mental health, improve their quality of life. And then it has impacts on either the individual, has impacts on the community in which they're going. And so maybe it improves their sort of less likely to get involved with violence incidents in the community, less likely to be victims of violence themselves. So this is quite a busy slide here, but I think the major issues for this around, well, it was a new service. It was just this hospital that was implementing the service has just been emerging from the pandemic. They'd had to delay start for quite a while because of that. It wasn't clear what the focus was for the evaluation. Are we talking about the impact on the individuals? Are we talking about the impact on the service, the hospitals themselves, or the impacts on the actual local neighbourhoods? And then there's a question about what sort of outcomes are required. There can be the engagement, the relative engagement between different population groups. Are there, for example, different types of population groups that are not engaging with this process, and there are certain groups that are? How is it affecting hospital reattendance rates? And then there's a couple of others which are really beyond the scope of what we were able to do, simply because of the lack of data that we had. That's around educational attainment and employment. And a lot of the data issues there you can see on the right-hand side were quite fundamental to how we approach this. There was data that the hospital collected data on the attendance at emergency attendance and reattendance. And the program, the Youth Violence Intervention Program itself, collected data on who was actually engaging with the service and who didn't engage with the service as well, and characteristics of those individuals. But there was no data link, there had no mechanism for linking between the 2 data sets. And the hospital didn't record on their data set, apart from occasionally in free text, they didn't actually record who actually was being recommended to move on to go into the Youth Violence Intervention Program. So there was a lot of issues here around the problems that we had with actually trying to do a quantitative evaluation of this, a full evaluation of this. And again, they didn't report the reasons for attendance. So our approach was really, as I was saying, it's primarily a qualitative data collection, a lot of around the experiences of the people administering the services and of clinical leaders. But our focus quantitatively was to look at what are the measurable impacts that we can look at. So we had things we could say something about access and reaching difficult groups. And then it was a question about making recommendations about how combinations of routine secondary care data and their own intervention program data can inform an evaluation. So it's about establishing the mechanisms by which they're going to be able to link the data. It's using particular SNOMED codes, for example, that the hospital will use that would then identify whether somebody is actually then starting to engage with these programs. And looking more widely, it's thinking about what approaches and methodologies would be particularly well suited for evaluating such services more generally. So a lot of the outputs were around recommendations about data capture, linkage, the sort of consenting process. There wasn't a formal consenting process that they had. How you measure outcomes, which outcomes to measure, and the different methodology options with a lot of pros and cons of the different approaches. The second evaluation is of peer-supported social care in prisons. Now, many prisons have got initiatives where prisoners themselves will provide informal support to other prisoners who have social care needs. So it's not this, it's outside the sort of a lot of them have their formal care plans, and that's administered by the local authorities, but there will be informal care, things like cleaning cells, if there's mobility issues, helping people to get around or getting things for the other prisoners. And it has anecdotally, a lot of advantages and in helping sort of self-esteem of prisoners, helping them to be supported where they need to be supported, and helping a much better environment to be in. However, there's been hardly any quantitative evaluation of these services in the UK or even throughout the world. There's no routine data that's collected specifically for this purpose. And there's several potential outcomes here. We're looking at the outcomes on the prison, on the buddies. The buddies are the people, the prisoners who provide the peer support, and then the prisoners who are actually receiving the support. So again, this was a mixed methods evaluation again, which is primarily qualitative, looking at the implementation and experiences. But we were thinking, is there anything quantitative that we were able to add to this study? We think yes, there was, because I mean, any full evaluation of this, you'd need to think about subsequently what data there is, and thinking about, well, what is the position that the data is in nationally, to be able to do any sort of evaluation of this, and to help help local authorities understand, for example, the values of doing these services. I have to say also there was actually nothing done on costing either on this as well. So we went back to basically back to first principles, and the questions really about what do we measure, and can it be measured? There's a certain amount of data that's being collected about prison services or criminal justice, but they don't necessarily useful for measuring some of the outcomes that are necessary for evaluating peer support processes. So the questions for us really about what are the important outcomes of peer support initiatives, and how could they be actually measured? And so our approach was really just centered around a literature review. We undertook workshops with relevant stakeholders, did some further interviews with experts, and looking at various data templates where we knew there was data that existed, was actually asking for some templates of what the data actually looked like. And we also piggybacked on the back of the qualitative evaluations within the prisons themselves, asking questions, putting questions into the topic guides about the type of data that they use, how they measure the impact of the services that they're providing within the prisons or by the local authorities. And so as outputs, we had basically, and one of the outputs, I think it's not mentioned there, had a whole list of benefits and potential benefits and shortcomings, an overview of the data landscape, various recommendations again on capture and analysis, and reflections on challenges of national quantitative evaluation. So to conclude, basically, quantitative analysts, they can bring more to the table than just number crunching. And I think a lot of the experience of using data, it's understanding how data sets are created, how data is collected, which I think brings a lot of useful information into an evaluation, being able to understand that and what's actually going on the ground. So as we said before, we need careful scoping to reflect what's likely to be achieved. You may need to go back to first principles. This question, or thing that also came up very much this morning, is about really giving the service realistic expectations, or managing their expectations. You know, if they want a full evaluation, full cost effectiveness evaluation, and they say you've got a year to do this, you know, you have to say as soon as you can, sorry, that's not going to be possible, and give them very good reasons why, and saying this is what we can actually deliver for you. I've talked about using data questions within the interview topic guides, and also facilitating future evaluation when more data becomes available. So it's providing things like evaluation frameworks, various tools, and supporting material that will help that to go forward. Thank you very much.
Thanks. I think we can. Yeah, we can share our appreciation of the speakers as we go. We're not at the opera, we don't have to wait till the fat lady sings. So our next speakers are following on with gaining quality insights under challenging conditions, and Sarah Reid and Cyril Lobert from the Nuffield Trust are going to speak. I don't know which one's going first, but Cyril.
Thank you, Paul, and good afternoon, everyone. So today, myself and my colleague Sarah are just going to be talking a bit about another piece of work that we've been undertaking as part of Reset, and I'll basically be going through the background of what patient-initiated follow-up, or PIFU, is, and then Sarah's going to talk a bit about the challenges that we've encountered and some solutions that we've come up with along the way to deal with those. So what exactly is PIFU? Well, it's a fundamental change in how outpatient care is organised. So instead of your standard fixed follow-up model where a patient might be seen every 6 or 12 months, a patient on PIFU is empowered to get in touch with the service as and when they need it. So a PIFU patient, say, if they have a chronic condition, when they have a flare-up, rather than waiting a few months to be seen or having to go through their GP, should be able to get in touch with the department and be seen by a specialist within a matter of days or weeks. Now, PIFU, it forms a really important part of NHSE's core elective recovery plan, and basically the hope was that by getting 5% of outpatients onto PIFU by March, that would result in a significant drop in outpatient attendances and free up more capacity for the patients that most needed it, for to get more people off the waiting list and seen by a specialist. But in reality, little is known about whether PIFU actually works to achieve these goals and how it impacts the staff delivering the service and the patients who are actually on those PIFU pathways. So we went about this, or are going about this, with 6 core research questions. Essentially, these look at how PIFU impacts the service, how it's actually being implemented in practice, how staff are engaging with it and what their perceptions of it are, and in what ways progress is being monitored. We're taking a mixed methods approach to this. So Chris is leading the quantitative team, and they're looking at both local and national data sets to understand volumes of PIFU, as well as, hopefully, PIFU's impact on outpatient activity. And then Sarah and myself and the rest of the qualitative team are looking at we're going and speaking to staff delivering the service and patients receiving the service to understand what it looks like in practice, and their perceptions of barriers and facilitators and different opportunities and risks associated with PIFU. So now I'm going to hand over to Sarah to talk a bit about those challenges.
Thanks, Cyril, and nice to be here with everyone. Yeah, so I think some of the challenges I am going to speak to flow really nicely from the session we heard this morning, and I hope I'm sure are familiar to lots of you in the room who are doing evaluations in different parts of research in the current context. But I think a big issue we've had is just this one about the time pressure and constraints on NHS organizations right now in this current moment of time. Here we are trying to understand how something's happening in outpatient care at a time when there, as Charles articulated this morning, extreme crises in A&E. It's hard enough to, in the trust we've worked with, it's hard enough to find consultants who are even able to take outpatient appointments at the moment, never mind talk to people like us for the sake of research. So it's been really difficult to actually identify it and have sites work with us on this study and engage with us over time. So a few things that we've done to be pragmatic and go about that. So we've definitely had the unfortunate situation of trusts just having to pull out of our study halfway through, just citing just lack of headspace and capacity to kind of lend that time to us for our study. And rather than start from scratch and try to build new relationships and come up with new case studies halfway through, we were pragmatic and said, actually, some of the most interesting variation and learning around PIFU is about how it's going to look in different clinical areas as much as different organizations. So we actually just expanded the number of clinical areas and specialties we're looking at in the sites that we still have locked in and confirmed are still working with us to try to get the same number of interviews and insights we might have, rather than try to start over again in the middle, which we thought would be quite difficult to pull off in a rapid study. And I think in things we might have done differently, I think we kind of went in with just being really selective about what would be the best case scenario. We want to talk to these types of organizations and these types of clinical areas because that's what seems really interesting in the data. But actually, looking back, we probably should have cast a much broader net, accepting that some insights will be better than no insights and kind of over-select. And I think that's something we could have done differently. We've had to play catch-up kind of halfway through as we've had these issues with engagement. And then lastly, I think being really creative about how we actually identify and find trust to work with. So there's lots of good forums out there like NHS Futures where trusts are actually going to talk about things like PIFU and how they're getting on with it. So there we were able to see a bunch of willing participants who are trying or navigating the very challenges that we're trying to study to identify who might be willing to work with us as part of our evaluation. I think another really big issue is one that also came up this morning, but here, PIFU definitely sits in one of those buckets of being a promising idea that's being turned to really quickly as a solution to some of the sector's most pressing problems right now, but it's happening at a time when we really don't know yet fully if it works. And we're working with NHS England and colleagues to kind of learn in real time what impact PIFU is having on the service, but also for patients and staff. And it's been really important to get that relationship right and set those expectations. And I think some of the things that we've been doing are what came up this morning as well. But I think just having that really strong working relationship with NHS England from the start to kind of lay out our independence and what our evaluation is likely to be able to answer, but what it probably won't be able to answer as well in this time frame. And also just being really willing to be transparent with our findings as we go. It's no use to NHS England if they're having to make decisions now about the next steps of PIFU to be holding on to our results for another 10 months until we're fully confident in them. We've had to kind of be sharing learning as we go and be willing to do that, but being very careful in how we do that to make sure, where there are still big gaps, but where things seem interesting or promising in different ways. And an example of that has been around, Cyril mentioned there's been a clear target for PIFU, and it was pretty clear early in some of our interviews that target might not be having the effect that NHS England intends in terms of, some of the biggest changes happening with PIFU is just that people are recording it for the first time. So is that really going to bring down weights and have an impact on service delivery if it's something that was already happening but being called differently and just something that people weren't recording in the data? So making sure they appreciated that, and also that having one target for the whole system might not make sense given how differently PIFU plays out for patients with different types of conditions and have different risks. So having a more nuanced approach to that are some of the things we've been feeding back early on. And then lastly, I think Chris just touched on a lot of this, but we've had a lot of issues with data quality that we've had to come to grips with. With PIFU, there was actually a new data source set up by NHS England to help us identify how many patients are being put on these pathways. But through our work, we realized pretty early on that there's lots of challenges with that. It's being reported inconsistently. PIFU is defined differently depending on the trust or organization you might work in. All of these things kind of play out in the data and make it really hard to see what's happening and what's happening to patients when they're on this pathway. So this is where having a mixed methods approach has really come into its own, because we've been able to kind of sense check what we're seeing in the data with the teams that we're working with in our interviews and help identify some really important discrepancies between what the data is telling us, but actually what seems to be happening on the front line. And we wouldn't have been able to do that if we didn't have this mixed methods approach and be able to test some of those assumptions with people who are actually working with this data. And I think also just, again, being really pragmatic, we had a dream that we would have 3 case study sites that also had really strong local data to work with at the same time, that we could marry all these insights together and have a nice narrative. And of course, that hasn't happened. The sites that are willing to engage qualitatively are not the ones that have the most mature local data sets. So we've kind of said, you know what, again, more insight is better than no insight. We'll cast a broader net. We'll go to where the data exists, but if they don't align perfectly with the sites we're doing our interviews at, so be it. It's better to have that insight than not. So just in conclusion then, so to summarize in how we keep making our rapid work rapid and some of the considerations we've had to do, I think the first 2 points just reinforce that pragmatism that we've had to take. If we not letting the great be the enemy of the good. If we went in and kind of waited till we got the perfect scenario, we would still be scoping this study. We really had to keep up with the pace of policy change and make some trade-offs and just accept that that's part of doing rapid work. And I think, again, not being overly selective, like having lots of backup options from day one would have been helpful in, if a site drops out, what are our other options? I think thinking those things through at the beginning would have been really helpful. And then the last point here, I think, is a really important one. We know we're not going to be able to answer every question on PIFU given the time we have, the kind of the quality issues in the data that I mentioned. So one of the things we are doing is kind of setting up a local evaluation framework so that the evidence can be generated after the lifespan of our study. And I think that's one way to kind of ensure that the insights don't stop just when the rapid work does. So I will stop there. Go on. Thank you.
Thanks, Sarah and Cyril. So our next presenters are covering that area that is probably most challenging in rapid evaluation work, and we'll probably pick that up at the end as well. Arlene Gallagher, who's Senior Analytics Manager for the Health Foundation, and Anna Ferguson-Montague, the PPI Public Contributor. So.
Thank you. I just have one slide, so that's good. I don't have to learn how to use this special buttons up here. So hi, I'm working at the Health Foundation. I'm just going to talk a little bit about patient and public involvement engagement within the remit of rapid evaluation. When we're thinking about rapid, we're often thinking about quick and speedy, and it often means that the first thing to go, if you're going to cut some corners, might be something like PPIE. People feel that it might be a bit complicated, it might be something that takes a lot of time, and therefore actually if I've got to do this quickly, then this is the bit that I'm not going to cover. But what we want to be able to say is that you can involve the public, even if you think you don't have time or the capacity, or you're unsure where to start. So I wanted to talk a little bit today about what we've been doing at the Health Foundation to try and enable this to be a bit better. So the first thing is we're trying to work towards engaging and involving the public being something that we do as standard in all of the projects that we do. So rather than saying, why do I need to do that? We instead say, why would I not do that this time? So we look at it from a different angle. And so what have we done to enable this? We've tried to speed it up a bit, tried to make it quicker, make it easier while still maintaining the value. So one of the things that we've done is we've prepared a database. So this is potential contributors. So we call this our PPIE network. Currently we have about 70 people on there that we can call when we need to, and that gives us a backup, so we can do this much more quickly when we've already got a pool of people we can go to. So one of the things we did when we were developing that was we surveyed all of the people and we asked them to give us information. So not just general demographics, but also what are the topics of interest that they might want to be called upon if it was if they're relevant. And so we have that information. So you can imagine our sort of database has got lots and lots of yes-nos in boxes, so we can go straight in and filter it down to the people that we think we might want to include in something each time. So that's been a really helpful way of speeding things up. We've also done a review of the best practice in the whole area of PPIE. What are the right way to do things? What are the best things? What have other people already done? And what did they learn from that? So that we don't go down the route of making mistakes that others have made in the past, and that we know what's the better and the most efficient way of doing things. And that's helped us as well to think about considering what the most appropriate forum is. So not just for the people who are involved, but also for like what we're trying to get out of it. So if we don't have a lot of time, or we can't take so many people involved in this, what's the best way that we could do that within those remits? So the barriers to getting people involved. So it might be that we have to think about whether it's one-on-one interviews versus having a forum with a focus group, for example, or maybe a longer engagement series. And we've got to look at which of those is most appropriate depending on the project that we're doing. We've also internally within the team created volunteer champions. So we went out and did a shout out for people to be involved in PPIE. And analytical teams haven't necessarily been the key people who were interested in this. A lot of people would say that they're the scientific side of things, so they don't really know how to do PPIE and not sure where to start. So we tried to encourage people to be involved in this and to be a champion for PPIE. And then we also signposted all of the key resources. So we tried to put everything together in one place so it's much easier for somebody who's starting a project during the scoping stage to look through and say, okay, these are all the things I need to think about if I want to get involved, the patients or the public, and how can I do this? So we're trying to create something that's an easy one-stop shop to go and find all the things that people need. And one of the main things we looked at was thinking about facilitating this. Because, again, scientific analytical teams didn't feel that this was necessarily their remit. So I think some people were concerned that they might hold a focus group with people who might want to talk about their lived experience, might get upset, and that maybe they wouldn't know what to do next if people, cried in front of them, and like how would they move on to the next part of this, and how could they get someone who talks a lot about themselves to actually stop and move on to the next person, and how do you facilitate all of that when you're actually, a statistician, and this is not really your thing. So we felt it was quite important to actually help people, to enable them to be able to do this so that it didn't feel like they were completely out of their comfort zone. So we did we've arranged some facilitation training with some people who are really good at this already so that we can learn from them. So it's another form of best practice, really. And so basically we feel that, when we are doing something rapid, we still think that it's really important to get patients and the public involved in that. And we've heard already really good examples today about why that's a good thing. So we tried to consider, what's the minimum I can do if I don't have the time, resources, capacity, but that we would still consider good. And so we're not just doing this as a tick box to say, yes, we had patient and public involvement and engagement in this study, but that actually we've thought this through, and we've tried to support the analytical teams to ensure that they look at this, as I said, as to why should I not do this rather than why should I? So I'm going to pass over now to Anna, who's been a really valuable contributor to many studies that we have done, and she's going to give us a few examples and her experience on this.
Hi everyone. I didn't know that back there's a step. I almost just went over backwards. That would have been a good start. So yeah, as Arlene said, often when we think about things being done quickly, we think about things that we're going to cut. But I'm here to tell you that you can still do it. And just some ideas of things that you can still do. Oh, I just need to change this slide, don't I? Aha. So again, we're looking at, obviously, if you've only got X amount of time, you might want to consider to use things that are already out there. So there are lots of things that already exist. So, for example, if you're in touch with your ARC, there are lots of ARCs that already have people that you can use. But obviously, one of the issues around that, if you go to the ARC and ask for people that have got a lot of experience and or kind of already know this field and what to do and what's involved, then you might miss out on getting the voice of the more excluded people. And that's something that you really have to balance up when you're doing this sort of work. So you might be needing to think about, have you got the time, have you got the budget to really get somebody in from scratch versus having somebody that's really experienced versus not having it at all. So again, that's something to really, to start to weigh up. Again, you need to really just kind of think about having this in place right from the very start. It's not an add-on, it's not something that's optional. It needs to be something that goes through every single thing that we're all doing. So then it's not an add-on, it's not optional. And again, it doesn't matter about how much time you've got. If you are going to involve people in your project, you need to be very clear about the timescales, what they can expect from you, what you expect from them, how much you're going to offer them. Are you going to meet online and in person? You need to think about accessibility needs of people and all those kind of things, and just be really, really clear. And I think that's one of the biggest obstacles that I found in my experience, that the expectations aren't really clear at the outset and people don't really know what it is that they're doing. And I'd like to say that when I was asked to come along here and speak, and I was thinking, oh my goodness, why have they asked me? Couldn't they get anyone else? And then when Arlene and I met and she was really clear with me about exactly what they wanted me to do, brilliant, yeah, really happy. So that was really key for me to be able to involve at my best and give my best, is to be told and be clear about what it is that I'm being asked to do. So then I'm just going to talk about a few kind of examples really in your studies, and I'm sure you already know about these things, but it's just that there are lots of, if you haven't got, if you've got a really, really short-term study, then you can think about doing some really sort of short-term activities. So again, email out some things that you want people to have a look at and email back to you. That's quite a quick way of doing things. Obviously, you might want to think about if you're then going to go back to people with the outcome of their input. Are you going to do that? Are you not? You just need to let people know. You might want to convene a focus group. And again, that comes with all the issues that Arlene talked about having the skills to be able to do that. And then obviously there are some, if you've got a bit more time and perhaps a bit more budget, a bit more experience, you might think of having sort of a joint a co-applicant to actually work really alongside you and really embed that kind of PPIE. You might want to go to conferences with that co-applicant to actually, jointly present what you found. You might invite your co-applicant to do some co-authoring of your reports. And I think one key thing to bear in mind with all this stuff is that when we're doing the studies and things, it's not just numbers, it's people. And I've just completely stolen that quote from the PPIE session earlier, and I thought it was absolutely brilliant, and that's really what we need to all kind of keep in our minds. And then I've just got some examples of things that I've been involved in, really. So I'm a member of the NIHR ARC West Plain English panel. So we get emailed things that they want us to have a look at in terms of the accessibility and the language, and we sort of edit them, really, for want of a better word. And often they're really quick. They're can you do this by maybe tomorrow lunchtime? So they can be really, really quick, kind of, and obviously they email them to quite a wide range of people as well, so then they're going to get a lot of different inputs from that. And also, on that note, a shout out to the ARC West YPAG, which is the Young People's Advisory Group, which is a group of about 65 people aged between 12 and 18. They're amazing. They do loads of stuff, so people quite often ask them for their input on various different studies, materials, leaflets. They're amazing, and they're currently inundated because everybody wants their input. So that's just a really good example of kind of how you can get input from people. I've done an article with somebody that's going to be submitted, and I've been named as a co-author on there, which is really brilliant, and again, really kind of helpful for me as well as for them. And I've given an example of where my input has led to sort of a really quick impact. I was talking about the scope of a project and was asking why that the unpaid carers hadn't been involved, and then as a result of what I'd said, they actually were involved. So that's a really sort of quick way and quick impact for me to sort of see, really, which is really, really helpful. And I think Arlene and I were talking about what I get from this as much as what I'm giving to the research and the studies, what I'm getting. And obviously I'm getting useful skills and useful experience. And I was thinking about this today coming here on the train, and actually being involved in, I do quite a lot of different PPIE for lots of different organisations, based on my experience of being a carer for my parents who have since passed on. And actually being continually involved in this has really helped me with my grief, because it's really felt like using their experiences of health and care system, both good and bad, and my experiences as a carer after they're not here anymore is really helping to sort of feel like there's a purpose in life, because it's helping to shape research to make things better for other people. And that's what we're all here to do, aren't we? And then finally, there was just a research article that I read that I thought people might find helpful. Okay, thank you.
So thanks very much. Just some reflection. So I'm co-lead of the NIHR's third Rapid Service Evaluation Team, REVAL or REVAL or REVAL, depending on which part of the country you come from. It's an accent thing in Manchester. And some of the things that the presentations have covered are things that we're reflecting on. So in terms of negotiating viable endpoints is something that we're currently working through, and managing expectations around what people can actually know at the end of a quite finite time frame. I think some of the issues around identifying and recruiting cases and facilitating access to case sites is, again, a challenge, and also sharing that learning in bite-sized chunks in meaningful ways as you progress. And then finally, ensuring that there's a public voice in the work that we do, in all the work that we do. And just picking up on Anna's last point about the young persons panel, so we're very fortunate in Greater Manchester to have one too. I've been there recently. We're evaluating the Successor Programme Special Measures, Recovery Support Programme. Didn't think the young persons panel would be overly interested in that, but actually it was one of the most fulfilling hour and a half I've had as a researcher in a long time. And their analogy of this is just the same as Ofsted and schools, and lots of insights around what you as a pupil or a patient might want to know about how a support programme is progressing and whether improvement is actually being made on the ground, has actually informed some of the questions that we're taking forward to the stakeholders that we're interviewing. So I think public voice is challenging, but it's something that we should all be trying to build in as much as possible and making sure it's meaningful in the way that Anna's described. So thanks for those presentations. We will take questions. Fortunately, there's people who know how to work microphones who are going to come amongst you, which is good for me. If you just want to raise your hands, Jay.
And this is a question actually for the PIFU system. I'm always interested about capacity as well. So you, of course, patients can initiate follow-up, but then how do you manage that, marry that up with capacity? Because that's going to be an end result that's going to limit your patient experience being either good or bad, whichever way. Because we've been trying to look at this in primary care as well. So can patients activate a problem to make sure there's complete resolution of that problem rather than just constant access for everything and anything?
Yeah, so that's a very interesting reflection, something that as we've spoken to more and more clinical teams, we've realized that most don't really have a good handle on that. And this actually, one issue that we have exposed in our work so far is that because there hasn't been much sort of active reflection or evaluation within those teams or local data collection on those sorts of issues, there's a real lack of knowledge on how it's impacting those sorts of capacity issues, and has been identified by some people as a potential sticking point in the future as they move more patients over onto PIFU.
Yeah, I think that question about what do we mean by capacity? What is the impact of PIFU going to be? Not just in terms of volumes of appointments, but what does it mean for the workload of a clinician in a day? Those are some of the things we are picking up on, and it's quite hard to measure in some of the quantitative data we have. But for example, one of the things we've been hearing is that what often consultants are left with under PIFU are just patients who are all initiating care with a problem. So they're actually able to do fewer appointments in a day, which I think is a result of different service changes that we've seen implemented in the sector, where in terms of different skill mix changes and things like that can be one of the unintended consequences. So we're trying to kind of understand what we mean by freeing up capacity, and how that plays out for different roles, not in primary care as well. But yeah, hope that answers your question somewhat.
Yeah, right in the back.
Hi, my name's Ruth Whately. I'm in the Integrated Care Board in Bristol, North Somerset, South Gloucestershire. So I was just really interested to hear you mention, Sarah, like the legacy of evaluation, because I haven't actually heard anyone else mention that today, and whether people in the room or the panel think there is a role for that. And I used to work in frontline mental health services for homeless people, so people with the worst outcomes in our country, and it felt like there was like one person in one of the biggest agencies in the UK doing evaluation. So what is the role of like us in the room and the legacy of building, I guess, frontline providers, GPs capacity and that kind of stuff? I think I just wanted to highlight that.
Yeah, I can start, and I'm sure others on the panel will have views on it too. But yeah, we saw that as one of the biggest things we could leave as a result of this evaluation. I think it became really clear that we would not be able to answer all the questions we wanted to, and that ongoing learning, if PIFU is going to be happening, and it's going to be continually scaled and spread, and that's the direction of policy. How do we keep learning from that experience? And so and this was something actually NHS England really highlighted as something that we could contribute. So we've been trying to think both, what are the qualitative insights and the quantitative insights, and there's all sorts of changes happening in the data as well. That as it gets more mature, we'll be able to answer different questions down the road. So I think we've seen that just as a really important feature, and probably something that we should incorporate, or maybe do incorporate as standard as in most of our evaluations. But I don't, Chris, if you had a view, or anyone else.
That's true, and there's a lot around. Particularly with some of the quantitative sides. If you're thinking of things like, is this cost effective, for example, and sort of questions that you really struggle with over a rapid timescale. And the rapid evaluation really isn't set up to. You might be lucky to be able to do it with some evaluations, but a lot of them you don't. And I think it's a case of then asking that question: how do you make sure that they've got that they're, first from a data perspective, are they collecting the right information? They've got the data processes together to be able to do a cost effectiveness analysis later on, or are they just going to be in a position where they're never going to know it's cost effective because they've not done that, set those things up? And so anything we can assist with to provide that legacy would be we think is very helpful. There's a big question about what you actually then provide and how you get that used and everything, and that's a whole different question altogether, which is very complicated. We could spend a whole afternoon talking about that, but I think that's the aim anyway.
Hi, I'm Camille. I work for the Health Innovation Network. I've got a question for Anna about PPIE. You mentioned something about being very clear about setting expectations. And obviously, that makes sense. But as an evaluation, change in scope, the timeline shift, do you have any example of good practice you could share about how you were communicated about, shifting expectations, or, anything you could share practically that helped you?
I think that's a really good question. I think all I can say is just keep people informed. I think especially when things are changing very quickly. And obviously you can say at the outset, this is what we're expecting. However, it may be subject to change. And I think it's just about keeping people informed. So if they don't, I won't be in touch with you until we know this, or until this changes. However, if anything does change, we'll be in touch, and also kind of be very explicit about kind of how you'll keep in touch with people, and also talk about what is the best way for them. Do they prefer an email all the time something changes, and that might be something that you just can't do because that may just be if you're in something that really is going to shift rapidly, or would they prefer an update once every month about the overall kind of changes to things, or would they just prefer to meet again if you have that in your budget to do an update meeting? So I think it's about just being really clear with people about what they can expect every step of the way, really, especially when things are going to change in that kind of timescale.
Okay, I've got probably a question for Arlene, actually, just in terms of PPIE. So most rapid evaluation teams that are represented in the room today are geographically situated, so we can draw on public patient involvement that from our own locale, but we're often engaging in evaluations that are national or have a national footprint. So how do we ensure a voice from other communities is heard? Have you got any experiences or tips you can share with that?
Yeah, that's a good point. Most of the work that we do is national. So our thinking behind collecting our network was to be able to collect that sort of demographic, but also, where are they information, so that we could make sure that we've included people with that in mind. So that would be something that would be worth considering for a local area, that if your studies are mostly within your local area, but you're going to want to present this as a national picture, do you need to have PPIE from across the borders, or into other devolved nations or other parts of the country. So I would encourage people to have a network in the same way that we have, so that you've got a pool of people that you can go to that will cover the areas that maybe you don't normally go to.
Any other questions? You've all been enlightened to such a degree that you get an extra 5 minutes for your break. I've got one up front.
Thank you so much to all the speakers for such an interesting session. I'm Nina at the Nuffield Trust, a researcher, and I was really struck by, Anna, what you said about not overlooking certain demographics when thinking about PPIE, and even considering ways to, I think, use the term upskill. Yeah. I wondered if you had any examples of what that might look like, and hypothetically, if organisations were thinking about trialling innovative new ways, testing out different types of PPIE engagement, what could we explore?
Yeah, I think that's such a brilliant question, and I wish I had all the answers to that. But I think it's about, I was having a really interesting chat at lunchtime, actually. It's about not kind of putting people in boxes. So we often just kind of assume that we've got this person from a particular background or from a particular group, and it's easy to just assume that they're just that person. That's all that we see, and we're not seeing that their background, that they might have done different jobs or have different skills. So I think it's not to actually assume that they even would need upskilling. Actually, that's probably the first thing to say, but also to kind of look at what they can bring to the table, what they want to bring to the table. So kind of again, it's not possible, but just think about a very basic kind of like a skills audit, I suppose. And I guess asking them, is there anything that you would need help or support with in order to be able to take part in this? So it might be around kind of accessibility to the internet, or it might be accessibility to a building. It might be that they would prefer to meet you. I was looking at a study the other day, and the researcher had a range of different ways that people could get involved. So they could have a phone call with her, they could have a one-to-one meeting with her, they could have a group call, they could have a group Zoom, they could meet as a group. So there was lots of different ways, and I think that's one of the key things. If you offer people choice, rather than being absolutely key, this is the only way that you can get involved, if we can make it as wide as possible, then I think we're going to get the most wide, the difference of people being able to take part. And I think, again, I think my answers are talking kind of ideal world, really, because I know this is not always possible. If we can go out to people, so if we can go to meet people in their spaces rather than ours, that can be really helpful, and certainly a lot less sort of intimidating if people haven't been in like the research world before. And I think just making yourself kind of accessible to people as well, but again, keeping in mind that you need to have a boundary. And Arlene's point about, not knowing what to do when people start crying, I think is really key, because obviously as a researcher, you're not a counsellor, you're not a friend, and often those things can be a bit blurry sometimes, particularly when everybody's new to it. So I think it's just trying to keep those things in mind. Basically, you've got to be absolutely great at everything, but yeah, easy. And I think just giving as wide a range of opportunity as you possibly can. And I think also then somebody mentioned in the PPIE session earlier about ambassadors, and I think again that's a brilliant way of getting people involved. So if you've already managed to recruit from a group that is sort of seldom heard, then if you can get those people to go out and spread the word, brilliant.
I'll just add something there. When I talked about the network that we've created, how we asked them what they're interested in, and we've recorded that, we were also acknowledged that might mean that we would only ever ask them about those things, and we acknowledged that wasn't necessarily what we wanted. I mean, that was helpful, certainly in from a rapid point of view, that we could go straight to people who we knew were interested in this sort of thing. But we're also working on sending semi-regular newsletters out about other things that are coming up. should people want to put themselves forward to take part in something that they maybe wouldn't have necessarily said in advance that they know that they'd be interested in, and what that might involve. So it's just to be able to open the door a bit wider to pick people up. So, yeah.
Thanks, everyone. I've really enjoyed this session. I actually just wanted to add on, because I don't think it's been something that's mentioned. My name is Chamut. I work with Arlene and others at the Health Foundation, and I have a lot of interest and a background in PPIE. And I think that particularly when doing rapid evaluation, that sometimes a really good starting point is also to look at third sector organizations and patient advocacy groups, because oftentimes they're able to distill issues that are of the most concern and turn it around very quickly. And they also have probably long-standing relationships with patients. And especially for those seldom heard groups, they're obviously a very big priority for those types of organizations to reach. And so it's a bit of an easier in as well. So I just thought I'd flag that.
Thank you. Okay, so that's us at the end of the session. Oh, we've got one final question. You're not in my eye line.
Who's going to get there first?
You've got two offers.
It just made me wonder, the size of the network that you currently have. Could you say something about it? And perhaps also in relation to the previous question, the extended reach of the network that you're directly able to contact.
Sure. So our network at the moment contains about 70 people, but we're actively working on trying to expand that. And we've done a piece of work to look at what do we not have in that list. So where are the spaces, and where are we maybe overrepresenting versus where we're not. And so we can start to look at where we might want to reach out to find some more people to put on that list, and in which areas do we want to do that. So that is our next step forward. Yeah.
And one at the back. You're doing all the legwork.
In answer to that particular problem, you might wish to consider reaching out to existing patient panels like the Adam Brooks panel and the university panel. One at UEA springs to mind straight away. Might be an avenue that's worth trying.
Absolutely, really good idea. Thank you.
This is the final question.
Oh, I knew I'd win that one.
Yeah.
And sort of following up, really, I'm minded of what we were talking about this morning, and this issue of the learning from evaluations often being lost and kind of recreating the same sorts of questions, and the need to sort of synthesize what we know, because often that learning is transferable. It might not be immediately that context or immediately that question. And I wonder just if there's something about PPIE that we need to be thinking about in relation to that too. That I think often when we report on PPIE in reports and in other ways, we talk about what we did. But I wonder how often we talk about what we learnt from that, because if we were to share that more as a community, that can be a starting point. Now, that's not to say that we then don't engage. It's not an either or, but actually I suspect there's a huge repository of transferable learning from previous activities across the country that could be the starting point to really then nail what is the engagement I'm going to do, because it's going to add value to what I already know. So it's just a sort of contribution rather than a question.
Yeah.
Thank you very much. Okay, can we all show our appreciation for what's been a really interesting session?